What would it look like for you to attend a doctor's office that gave you up to an hour for visits, that let you text them whenever you had a question, and that also had a pharmacist on staff who actually had the availability and the capacity to help you with your medications? That is the reality for patients who are using direct primary care providers. And I am so excited that today we have, as our first guest on the Health Literacy IRL podcast, a pharmacist who practices within a DPC clinic. Welcome to Health Literacy in Real Life. This is a show where we move beyond personal health literacy and we explore organizational health literacy, how systems and institutions are making it easier for people to understand and use health information in their daily lives. I am Megan Freeland, if we haven't had the chance to meet yet. I'm a public health pharmacist by background whose work is a blend of organizational health literacy strategy, patient advocacy, and patient education. And today I am joined by a very special guest, Dr. Ellen Jones. Dr. Jones is a pharmacist and an associate professor of pharmacy practice at Harding University College of Pharmacy in Arkansas, where she teaches courses in self-care pharmacotherapy, immunization certification, and patient-centered care. She practices as a clinical pharmacist at One Life Direct Primary Care, where she provides comprehensive medication management for a wide range of acute and chronic diseases, as well as preventative care. Dr. Jones and her team are doing something incredibly interesting, and I'm so excited for you all to learn more about the direct primary care model and how it is inherently helping patients improve their health and wellness. So, Ellen, welcome to Health Literacy in Real Life.
Hi, thank you so much for having me. I'm so excited to be here.
I don't know if I told you this or not, but you are actually the very first guest on the podcast. So you have a special role that you're playing here. I don't know if your episode will be the first guest episode, but for the record, you are the first guest recording.
Dear Diary, today I was the first guest. I'm so excited for you. That's awesome.
Thank you. So I am excited for you to let the listeners know a little bit more about direct primary care because as I shared with you when we first met, I have probably known about this model for maybe a year. And when I first learned about it, I was suspicious. I was like, this sounds too good to be true. This is a scam. This is not real. So I would love for you, actually, before you tell us about direct primary care, tell us a little bit about how you even got to this path. Like, what did your career path look like?
So, my journey to pharmacy is maybe a little unique. I was a stay-at-home mom and voice teacher and piano teacher while my children were young. And then when my youngest daughter started kindergarten, I went back to school. I was a music and theater major
Oh,
in
wow.
undergrad and did several things before that. And then I went back to school and graduated with my PharmD in 2016 at 40 years old. So I've really appreciated my backgrounds in the performing arts as it relates to my practice as a pharmacist. I believe I have better communication skills through that than I would have had without. That has really informed how I approach my practice as a pharmacist. So I graduated in 2016 with my PharmD. I did a PGY1 residency at White River Health System in Batesville, Arkansas. And then when I joined faculty at Harding, a physician in town was just leaving the health system to go out on his own to start an independent clinic. And I was coming on board, and then he was starting this new clinic, and we were already acquainted. And I was like, this sounds like a great practice site for a pharmacist. You'd like to have a pharmacist, wouldn't you? And so that started the conversation. And lo and behold, that is what came to pass. And it was just a traditional fee-for-service clinic. I was embedded there as my clinical practice site as a faculty member, and I did a variety of things. I did medication reconciliations. I did some refill requests. I did prior authorizations. I did some annual wellness visits, and then just being available for those curbside consults. Can you go talk to this patient, explain their insulin, just whatever was needed. And then a few years into that, the physician, his name's Joe Duggar, he transitioned to the direct primary care model. And because I was already there, I went along with him for that. And it's been really rewarding.
Did you know what DPC was when Dr. Duggar decided to make that transition, or was it also a learning opportunity for you? And also, I have to shout out the music background. I did not know that about you, but I actually grew up playing piano and flute all throughout my schooling. So, musicians in pharmacy, we've got another connection here.
Yes, flute girlies. I played flute for 7
Yeah.
years.
Oh my gosh.
Yes. And then when I got to college, I went more the voice route.
Okay.
So, yeah, I sang with the Nashville Symphony for 7 years. So, I have a long performing
Yeah.
background, and I
That's
love it.
amazing.
I love it, and I try to stay as involved as I can, for sure. But as it relates to me knowing and being familiar with DPC, absolutely not. I'd never heard of
Okay.
it. The main idea is there's fewer steps between the patient and the physician. The healthcare system today is gigantic, and there are
Hmm.
so many moving parts. And it is what it is. We need that in place currently because it's the way it's structured. But there are some physicians that have essentially opted out of that
Hmm.
system. So, DPC is where a patient pays a subscription to be a member of this clinic. And it's a variety of pricing strategies. Sometimes it gets confused with concierge medicine or executive medicine. Typically, in concierge or executive medicine, the clinicians are still billing the insurance, but then
Hmm.
these patients are paying extra for added services or added attention, added accessibility. DPC is different in that we don't bill insurance. We're not asking for any third party payer. The relationship is directly between the patient and the clinician. Because we have the direct communication and the direct patient care, there's more time a lot of times
Hmm.
for the level of attention. Now, it's not always. We can also do things quickly. It's not automatically that we make our appointments pretty much hourly, sometimes every 30 minutes, but it's not like you're required to be there.
Not holding you hostage for 30
Right,
minutes or
right,
an
right,
hour if you don't
right,
need to be there for 30 minutes or an hour, but the option is there for you.
right. Right. And one of the best things I think is we can customize the appointment to what the patient needs in that moment. And so
Mhm.
sometimes it's something big that we do need to take the time. So it's a new diagnosis of diabetes, right? There's a lot of education that has to happen to learn how to manage these disease states. And we have the time for that. And we don't have to necessarily outsource that. We don't have to refer out because we have the time to do that ourselves. We're
Mhm.
all trained in that. As a pharmacist, we learn how to educate our patients in diabetes. And so we can take the time to say, this is how your insulin works. This is how you put a pin needle on your insulin pin, etc. And nutrition, we can take the time to talk about the diet and the exercise. And at the same time, there's other things that maybe only require a text. So, for example, I don't know, someone wakes up in the morning or they know they're going to be riding on an airplane and they know they are going to get sick, right? They know they experience nausea. And so they text us and we send in the prescription. We don't have to wait 2 weeks to get that prescription to get that, or I'm going on a cruise and I need a scopolamine patch. Something
Mhm.
simple like that. Okay, great. We'll take care of it because we've already got the relationship with the patient. We know things about them that we don't have to say, well, make an appointment because from a financial standpoint, I don't have to bill that CPT code to be compensated for that work that I did for that patient. It's already built in with the structure.
Exactly. Yeah. And I think that's the point. That's almost like the crux of what the model is solving for, right? Because without pointing the finger too hard, I think it is important to clarify for people that when they are going to their traditional clinics and they're frustrated that they're only able to see the provider for 10 minutes, maybe,
Mhm.
That is not a function of that physician's or nurse practitioners or whomever's desire to see you. I'm sure that most of those clinicians want to spend more time with their patients. The reason they're not able to is because of that incentivization model that comes from the third party payers, the insurance companies. And
Mhm.
so, what DPC is doing, as I understand it, is removing that middleman, removing that third party payer. So then the clinicians are not restricted by what they can be reimbursed for, what they can bill for. They're
Mhm.
able to provide more time and spend more time with their patients. I think that time element is inherently why the DPC model is a strong example of organizational health literacy, because
Mhm.
sometimes it's just that you have time to communicate, to educate, to ask questions, to engage, to counsel. And so I think it's really important to highlight that aspect of what you're talking about with DPC models.
Absolutely. And we also have other lines of communication. So a patient has a direct clinician line that they can text and get to the physician
Yeah,
24 hours a day, which he has signed up for, and he's fine with that. Most patients respect the work day, but if something's happening, that
right.
is built into our model that, let's say they come in, one patient comes in one day with an illness and we diagnose and we send the medication, they get the prescription from the pharmacy, everything went like it was supposed to. And then the next day, maybe they have an adverse effect or, some sort of side effect that or a question that they're not sure about. They are empowered to reach right back out
Mm-hmm.
to the physician to say, is this right? Is this okay? Should I be concerned? What should I do about this? And that's built into the model that it's this regular line of communication that there's fewer gates
Mm-hmm.
between the pharmacist as well. We have closer lines of communication with our pharmacies that we work with. They can text us to clarify something. It's easier to get to us.
Right. Even as a patient, I think about if I want to say something to my doctor, I even have to go in my chart and then hope that they respond within 5 days, or I call and leave a message with the nurse and then maybe they'll get back to me. But then that turns into a 2 week long conversation because we're messaging back and forth. And this direct text access is so much more convenient. There are actually health tech companies, a couple of which have been my clients, that
Mhm.
the whole value proposition is it's like texting a doctor in your pocket. And as a mom of young children, I use that service all the time because it is much easier for me to text those providers and get immediate answers, immediate prescriptions than it is for me to try to call my pediatrician and have to physically come into the office for something that I actually don't need to come into the office for.
Exactly. Exactly. You hate to hear, well, you're going to need to make an appointment for that.
Yeah.
And it's absolutely no shade on
Right.
anybody who's working in that arena. It's just the system. That's what the system has become. Everybody's doing their best, obviously, but the system does not always serve the ultimate goal of the patient or the clinician,
Mm-hmm.
honestly. In the name of value, we have limited ourselves. And in some ways, the system has outgrown its utility.
Mm-hmm.
And and I will say there is some risk involved for a physician to go into this model because there is some security in being a part of the system.
Mm-hmm.
So it is a risk financially, but for a lot of clinicians, the risk is worth it. And
Mm-hmm.
so it is a growing model. There are maps out there. You can Google these types of clinics that are in your local area. It's harder financially or from a business aspect to be sustainable in more rural areas, unfortunately, which is where we really would benefit from this. But at the same time, we do a lot of telehealth. And so we have patients who are homebound, but they still get full access to us via the telehealth, via the
Mhm.
text.
Well, tell me, as a pharmacist, I don't know if you experienced a transition in what you were able to do when you all were under the traditional model and then
Mhm.
when you transitioned into DPC. But
Mhm.
regardless, I'm sure that there are programs you've been able to enact, conversations you've been able to have that are different than in a more traditional pharmacy setting.
So when we were still traditionally, when working traditionally, I was able to do things, but because it was my faculty site and I was not employed by the clinic, they were not able to bill for my services. And every
Mhm.
state is different, with the way that pharmacists are able to operate, and with collaborative practice agreements and different things like that. So I did have some collaborative practice agreements for some chronic disease state management, cardiovascular, diabetes, hypertension, things like that. But now that we're DPC, I'm working very closely with the physician, and we're not worried about billable time or
Mhm.
having the right CPT codes and what can a pharmacist bill for. So there's a lot more flexibility in what I'm able to do. I make a lot of recommendations. I meet with a lot of patients to educate them. And then also, he'll ask me to meet with a patient to determine the plan, and
Mhm.
then we discuss it, and then we implement that plan. And so that's been very gratifying to me to be able to work. We say work at the top of your license. I think we all are capable of working at the top of our license. So something else that we've been able to implement is genetic testing for mental health medications. So antidepressants, anxiety, sleep, anticonvulsants, ADHD, antipsychotics. So we do genetic testing for those because a lot of times it can be really challenging to get the right meds for a patient because we have
Right.
these drug gene interactions. We talk about it a lot in pharmacy, right? We understand metabolism and kinetics and pharmacodynamics and all of those things. And so that's something that I can use the amount of time I spent thinking about those things and
Mhm.
apply it to an actual patient. So the physician I work with, he's been practicing for 30 years in this area. And so because I'm a newer pharmacist, I learned about these things in school. When he was in school, those things didn't exist. And so
Right.
we were able to get started on doing those things. I'm able to administer the test. It's a cheek swab. We get the results back, and then I look at those results. I look at their med history, all of the whole patient, and make the decision on what I think is the best way to go forward. And then the physician and I discuss it, because we do work very collaboratively, and then we implement that plan. And then I do the follow up as well. How is it going? And when we're dealing with antidepressants and things like that, it takes a few weeks to even know. And that's another way the DPC model is valuable is we don't have to wait. I don't send the prescription and then I might hear back in 3 months. I'm going to text you next week to see how it's going.
Right.
I'm going to text you next month. I'm going to see you next month to check in. And so there's more touch points, which is really with the people who are making the decisions. And that's
Mhm.
valuable. There's fewer messengers.
Do you know, outside of, like, just across general clinical practice, how common the actual implementation of the genetic testing is around mental health medications? Because obviously it's something that we learned about throughout school. It's something that we have these things in pharmacy that are touted as like these wonderful things we get to do, but then in practice, because of the constraints that we just discussed, we don't
Mhm.
actually get to implement those. And so I think it's amazing that you get to really hold the patient's hand throughout that process and give them a more personalized care experience. Do you know how different that is from general clinical practice?
I would say it's growing.
Okay.
I would say it's more and more because, so this is another thing about DPC is that our patients can have insurance, right? So we have patients that are insured, we have patients who are not insured with varying levels. We have Medicare patients, we have Medicaid patients who also choose to become members. It is growing because there's growing coverage for that type of test. I think probably the barrier, this is just me guessing, is how do you put that in your workflow?
Mm-hmm.
So we get our results back in 3 days for those genetic tests.
Okay.
But if you've just had that first visit with a patient in a traditional clinic, you're like, come back 3 days later and let's talk about it. That's harder to make happen when your schedule was already full for that day.
Mm-hmm. Mm-hmm.
I don't think that it's something that has to be limited to a psychiatry specialty. This is something that can happen in primary care, in family medicine, and health systems are starting to use pharmacists in these roles more. I think it's an awareness that it's possible.
I'm glad that you are here to spread that awareness, because I think this is what's important, is like knowing, one, that pharmacists are doing it, and two, understanding how. Let's talk about dispensing, because that's one thing that you have not brought up yet. How is dispensing involved in your job, if at all?
In my job, it is not at all because of Arkansas state laws. Every state has different physician dispensing laws. And in Arkansas, it has to do with patient access. So for a physician to dispense in Arkansas, they have to prove to the Arkansas Medical Board that their patients don't have access to a pharmacy, essentially. In other states, it's much more flexible. We work with someone from Colorado, and in Colorado, there's no such rule in place. Physicians can dispense whatever they want. And that is a pretty big component in a lot of DPC clinics. In a lot of DPC clinics, they act kind of like a one-stop shop where the physician chooses the medication and they dispense it right there. So I think this is a great opportunity for DPC clinicians to utilize a pharmacist, not only for the dispensing potential, but also for the clinical value that they can bring. And that might be the value add to their clinic that we as pharmacists, traditionally would be considered pretty expensive to bring on staff. But if you consider maybe your patient panel could be expanded because you have another clinician in the office who just happens to be a medication expert, how could that be a bad thing? And then if you are dispensing, who better to manage the dispensing of your medications than a pharmacist in your clinic? Another opportunity, I think community pharmacies are very well positioned to maybe fulfill that role for the DPC clinics. We have cash-based pharmacy models out there that I think are pretty fantastic. I think pharmacy as a profession, we're kind of getting into the same place as the traditional fee-for-service clinics are getting into. There's a lot of steps between the patient's dollars and my income.
Yep.
And there are pharmacists out there with models, Blueberry Pharmacy, right? Up in Pennsylvania. There's other pharmacies that are going cash-based. It might even be cheaper than using insurance and your copays. You could do a completely cash-based start to finish, and maybe a community pharmacy partners with a DPC for their patients with special cash prices.
Yeah, this is great, because you're laying out the opportunity not only for the patient, but for the DPC clinic and the cash-based pharmacy as well. You're given a lot of different pieces of the puzzle, different options on how to make this a more mutually beneficial system for all the players involved. And when we spoke before, you also shared with me another way that you have been able to add value as a pharmacist in terms of patients who are getting their medications elsewhere, all of whom are, because you're not dispensing in clinic, but then they bring those medications back and they're still able to have conversations with you about them. Is that correct?
Absolutely. So for example, if we're starting a diabetic patient on Ozempic, right? There's a learning curve on how to use that drug, or some inhalers, different things that there's a pretty big education component to it. We can send that prescription, and a lot of times clinics will send a prescription and assume that the pharmacy is going to take care of that education piece. And that may or may not be possible based on the workflow of that particular
Right.
pharmacy. If there's no direct line of communication, which there rarely is between the clinic and the pharmacy, we kind of both think the other is going to take care of that for us.
Mm-hmm.
And then if the patient is not a strong advocate for themselves to ask the right questions, they get home with a device that they don't know anything about. And then they're not sure even who to ask. And so what we're able to do is if I send a prescription for Ozempic, right, that comes with the pin needles and there's a lot kind of to that, I'll say, go pick up your medication, bring it back, and let's work through this.
Mm-hmm.
And I'm able to do all of the education, all those things. And that's not extra billing. That's built
Right.
into what I do. And so there's not another copay for that education.
This is a great example. I'm glad you brought this up because I spend a lot of time on Reddit, just like seeing what people are saying about different health topics, medications, etc. And the GLP-1 threads on Reddit are full, popping 24/7. A lot of what people are complaining about is the lack of support that they get with starting and maintaining the medications. And in a lot of cases, not having the proper counseling up front or during the process to help them mitigate the risk of side effects. This is a perfect organizational health literacy example because the model inherently creates that opportunity for you and that patient to have more time together and more touch points more seamlessly, more conveniently, and that directly translates to that patient being able to better care for themselves, better manage their treatment experience. So I'm glad you brought that example up because I think it just again drives home the point that sometimes the solution is not some magic formula, right? It's like more time, more touch points,
It
more
is.
convenience, which is really all that patients and, to your point, clinicians are asking for.
Yeah, and because an added level of difficulty to those is we're changing the dose every month,
Mm-hmm.
potentially. And, and that's not the normal workflow of a clinic. It's we prescribe your medication and then we'll see you in 3 months, for diabetes, because we're going to get your next A1C or something like
Mm-hmm.
that. And with my patients, at least, and I'm sure other people are doing this as well, is if someone is doing well on a particular dose, I'm not going to increase it. You don't have to automatically increase it, but I don't know that if I've not had a conversation.
Right.
And so it's built in. Or if they increase the dose and they're like, nope, that wasn't it, then we get to go back down. So it gives the opportunity. And I don't want to sound like I'm saying other clinics are not doing this or do not have their patient in mind at all. But it's maybe a bigger challenge to make that happen
Mm-hmm.
because of the constraints on their day.
As we are spreading the word about DPC and how helpful of a model this can be in some ways, one, acknowledging that it's not perfect, nothing is perfect, has its limitations. And also, there are benefits to the traditional model for some people. I think what we're trying to do here is just raise the awareness that there are other options and other models that do inherently give each of the stakeholders more of what they are looking for in a care experience and elevating some of the aspects of that model that maybe other clinicians, patients can think about and find ways to create those opportunities in their spaces as well. What would you recommend for other pharmacists or even other clinicians based on your learnings within the DPC model?
I think the first best step is to start developing relationships. I can't just go up to a doctor and say, "Hi, I'm a really good pharmacist. Let me do some work for you."
Mhm.
But start the conversation. I'm interested in how you do things. This is new to me. I wonder how a pharmacist might benefit you. Think about what challenges do you have as a clinician when it comes to medication access for your patients. Find out how you can be the answer to those questions. And maybe there's one day a week that you come in and answer all the medication questions. If the physician wanted to offer clinical pharmacy services and that's an
Mhm.
extra cost. There's a lot of ways because we're not constrained by the structure that we're used to. It
Right.
really, sky's the limit. You can build the relationship that you want. Maybe if I'm an entrepreneurial minded pharmacist and there are 4 DPC clinics in my state, I call them and I say, if you have any complicated medication cases, I'm happy to look over those for you.
Mhm.
Do that, do a good job, right? Be good at it. And then they're going to maybe call you next time. Become a resource. That's one of my favorite roles as a pharmacist is to be a resource. My very favorite thing is if I've been gone from the clinic for a little while and I come in and they're like, I'm so glad you're here. That is
Mhm.
my favorite thing in the world as a pharmacist is to feel like I'm able to fill in somebody's gaps.
Yeah.
And there's plenty of gaps
So
that
many
we
gaps.
that we're equipped to fill. It's looking for them, finding them, and then offering.
Wow, well, we got to see Professor Jones come out a little bit at the end because you gave you gave such practical and actionable suggestions. I appreciate that because that's really what I wanted pharmacists to hear, that even though, your situation is very specific because of
Mhm.
your faculty position, that doesn't mean that's the only way this works, right? There are other ways for pharmacists to engage in these models and expand what patients experience as their benefits. So you gave a number of suggestions. I'm sure there are probably others that folks might be able to create, but I think
Mhm.
your point is get creative, get resourceful, get entrepreneurial. And if anything, the growth of DPC should hopefully serve as a launching pad for even more clinicians, because it's not just physicians that are experiencing the challenges of this system. It's dentists, it's pharmacists, it's everyone. So I
Yes.
hope that the growth of this model has an expansive effect on the broader clinical community, including pharmacists. And I thank you so much for being here to shed light on what that experience has been like for you and give fellow pharmacists suggestions on how they can create more of these opportunities for themselves as well. If people want to follow up with you, learn more, is there a way that they can contact you or keep track of what you have going on?
Sure. Well, I'm on LinkedIn and I'm happy to connect with anybody on LinkedIn. Ellen Jones PharmD. I think this is a really cool opportunity for us as pharmacists who are looking. I'm on the Pharmacist Moms Facebook group,
Mhm.
and a couple of people have reached out to me and sent me a message and said, how do you do this? And I help as much as I can. I recognize that I'm in a unique position, but I really do feel like the opportunity is there. It's work. I'm not going to pretend that getting someone to invest in you as a
Mhm.
pharmacist, as a clinician is going to be easy, but I think that there are ways. One afternoon a week, I'm going to do this for you. Doing something that feels doable yet valuable, but the better we can develop the relationships between the prescribers that we work with,
Mhm.
improves outcomes for everyone. It makes our patients better. It makes our patients more informed and ultimately makes our community more healthy.
Yep. And that's the goal. That's what we're trying to do here. I
Mhm.
love it. Thank you so much, Ellen.
Yeah, thanks so much.